Welcome everyone to our webinar today. This is to release the findings of our 4th annual stakeholder survey on the state of comparative effectiveness research in the United States. And look forward to the conversation today, sharing our results, and then hearing from a couple of our guest speakers who are intimately involved with CER in this country. Now, surveys provide a snapshot in time just by offering us perspective on what folks think at any given moment. So we surveyed a number of stakeholders who follow comparative effectiveness research quite closely, and that's what you're going to see today. They also provide a baseline to be able to track changes and trends from year to year. And when it comes to CER and the environment for healthcare decision making, we've been tracking those changes and really keeping our fingers on the pulse of stakeholders for the last 4 years. Since we took our first snapshot of stakeholder perceptions in 2011, we've seen some shifts, particularly in which organizations these stakeholders consider to be leaders in particular areas related to CER, such as establishing standards, conducting, monitoring, and funding of the research. It's also clear that stakeholders today are more familiar with CER than they were a few years ago. That's probably because CER has been getting more attention since then. It's in the news more, it's in the media on a more regular basis. We're hearing about it more in our daily work lives. In addition, PCORI, the Patient-Centered Outcomes Research Institute, has been up and running for a few years now, and they've been actively funding millions of dollars in new CER projects. So what do the stakeholders think about CER and its impact on decision making? Because at the end of the day, that's what it's all about, the ability to inform individuals to help them make better medical decisions, and they affect healthcare and the healthcare environment. To walk us through the answers to that question and additional questions, I'm going to introduce Kimberly Westrich. Kimberly is our Director of Health Services Research here at the National Pharmaceutical Council, and for the last 4 years has led this survey project team with us here at NPC that she's conducted in conjunction with the group Social and Scientific Systems Incorporated. And after Kimberly's remarks, we're going to hear from our two guests, Dr. Joe Selby, who's the Executive Director of PCORI, and Dr. Jean Rich, who heads Mathematica Center on Healthcare Effectiveness and is a Senior Fellow there at Mathematica. They will provide us with some outside perspectives on the survey results, and then we'll open up for questions.
Thank you so much, Dan. I'm so happy to be here today to talk about the results from our 4th annual survey. Before I get started, I'd like to give a big shout out of thanks to our research partners at Social and Scientific Systems, Inc., Claudia Schur and Annalise Adams, who have been our partners in this survey for 4 years. This slide shows you the folks that we interviewed for this survey. We had a number of respondents, 110, and these are the major audiences that NPC interacts with. So that's how we put together our stakeholder list. These are all folks who've indicated that they're knowledgeable about comparative effectiveness research and its role in healthcare decision making. Now, throughout my presentation, you're going to see a few slides that have this key logo on them. Those are the takeaways that we've identified as the key takeaways. So when you see a key, pay particular attention. Those are the findings that we think are some of the most important and interesting from this particular survey. The first finding is that comparative effectiveness research is still important to our stakeholders. When you look at this slide, you'll see the results from all 4 years of the survey. 2011 is at the left, 2014 is at the right. The purple parts of the bars are the number of people who said that CER is very important to them or their organization. The green sections of the bars are somewhat important, red is slightly important, and a couple folks in blue said it's not at all important. The major thing that we see when we look at this slide is it's still very important to folks overall, especially if you look at the share that said somewhat important plus very important. That's been pretty similar over time. One thing that I do notice in this slide is that the share who have said it's very important That's been decreasing slightly over time. In the first year of the survey, CER was very new. It was all over the media. PCORI was just getting established, and I think it took on extra importance in those early years. Now, this next series of slides is going to look very similar, so I want to spend some time on this first slide sort of orienting you to what you're looking at. We asked a series of questions of the stakeholders, which groups they saw having an important role over the next 5 years in various areas. This particular slide that you're looking right now is research standards, so which groups played an important role in research standards. Each slide is going to have the same groups going across the bottom: AHRQ, NIH, FDA, PCORI, academia, private health plans, and industries. And within each group, like if you look at AHRQ, you'll see 4 bars there. Those indicate the survey results from each of the 4 years. So the turquoise bar is 2011, red is 2012, and so on. You'll also notice when you look at one of these slides that some of the bars are darker in color, some of them are faded. The faded ones mean I'm not going to focus on that for a particular slide, so it helps you sort of look at the slide and see what it says. So let's look at this slide. Who has a key role in establishing research standards? Stakeholders told us that PCORI has a leading role in this area, along with AHRQ, and NIH also plays a supporting role to those 2 organizations. And that's been pretty similar over time, although certainly AHRQ used to have a more dominant role and is now in a supporting role. I think that PCORI's release of the methodology report certainly helped to cement its part as a leader in the research standards role. The next slide has to do with which organizations will play key roles in establishing research priorities over the next 5 years. Here, again, you see PCORI with a leadership role and AHRQ and NIH having important roles in this area. This slide speaks to who has important roles in funding and monitoring research. Here you see a big jump in PCORI with this year's survey, and that's not at all surprising with all of the funding awards that PCORI has put out recently. I think stakeholders have taken notice of that, and they definitely see PCORI as having a very important role in this area, along with NIH. Supporting roles are played by AHRQ and industry. Now this slide speaks to conducting research. It's still very much the domain of academia and industry. Now something we noticed last year, if you look at FDA and private health plans and the green bars, which represents last year, you'll see that they started to show an increase. I think stakeholders were noticing that private health plans were looking more and more into big data. FDA was talking about plans to mine its data. And stakeholders indicated that they thought FDA and private health plans might be playing more of a role in this area of conducting research. But this year we've noticed that they've backed off of that view and returned to earlier survey levels. Now this is the last chart in this particular series. You'll notice there's only purple bars in this chart. This was a new question for this year, so we don't have any trend data. We asked stakeholders which organizations will play a key role in translating and disseminating research over the next 5 years. Stakeholders resoundingly said that this is an activity that falls to AHRQ. That's really not surprising since they're mandated to do so under ACA. And PCORI and academia also play a large role in this area, followed by NIH and private health plans. And I find it kind of interesting that private health plans are viewed as having as large of a role in this area as NIH. Now this particular slide, I actually probably could have put 2 keys on this slide. I think this is probably the most important finding in the survey. Now here you see 4 bars, but those 4 bars are not the 4 years of our survey. Each one of these bars came from this year's survey. We asked stakeholders the extent to which they thought comparative effectiveness research has had or will have an impact on healthcare decision making. So that very first bar says, what was the impact over the last year? And you'll see that 28% said they didn't think it had any impact over the last year. 56% said, well, okay, slight improvement. 13% said a moderate improvement, and only 3% of our stakeholders thought that CER had a substantial impact on healthcare decision-making over the past year. As you move to the right on the chart, the next bar is what will this outlook look like over the next year. And now you see that folks are a little more optimistic, with 57% saying slight improvement and 31% saying moderate improvement. Still only 6% are saying that there will be a substantial improvement over the next year. It's not until you move out a little bit farther to 3 years and 5 years that stakeholders really think that it's going to start to have a moderate to substantial impact on healthcare decision making. And the question here is why, and I hope that this is something that both Dr. Selby and Dr. Rich will speak to in their reactions. What could be going on here? Is it that there's not enough research out yet? Maybe there's not enough good research out or enough research that really targets the particular populations of interest? Or is there a lot of research, and it's good, but we're not doing a good job of disseminating it and getting it out there yet? Or maybe there's something else going on. I know Dr. Selby and I have spoken about this a little bit, and Dr. Rich probably has some great insights from all of the AHRQ evaluation work that he's undertaken at Mathematica. So the next series of slides that we'll look at are all going to look the same. So again, I'd like to orient you a little bit to what you're going to be looking at. This particular slide has a list of 9 issue areas, and don't feel like you need to read them all. We're going to work through each one of them on a slide. But if you look at the top slide, on the left, no agreed upon research standards. On the right, widely agreed upon research standards. So each issue area has a left anchor and a right anchor, and we think of the right anchor as being an environment that's more favorable for patients and patient outcomes. Stakeholders were asked to assess the environment along that issue area, and they were able to pick anywhere from 1, which anchors on the left side, to 7, which anchors on the right side, 4 being neutral, 2 and 3 were different degrees of being towards the left, 5 and 6 different degrees of being towards the right. So in the slides that you're going to see, we focused the left side answers, 1, 2, and 3, and the right side answers, 5, 6, and 7. So you'll see those answers grouped. So let's look at a slide and see what this might look like. So this particular slide speaks to the extent to which the environment is moving towards agreed upon research standards. And this is one of our key finding slides, as you can see by the key at the top of the slide. The left anchor is no agreed upon research standards. The right anchor is widely agreed upon research standards. And when you look at the pairs of bars on the slide, they represent the data from 4 years of our survey. So the leftmost pair of bars is from the original survey, where 50% of the respondents tended towards the left or the negative side, thought that there were no or few agreed upon research standards. 24% tended towards the positive side and thought there were more or widely agreed upon research standards. This particular slide shows a really nice pattern of progress. If you look at the last pair of bars, which represents today, you'll see that it's almost a mirror image. Now there's only 32% of respondents that are tending towards the negative side. 47% are saying, yes, there's more and widely agreed upon standards. And I think in part this is certainly due to PCORI's methodology report. This next slide speaks to the extent to which research priorities adequately address the treatment choices faced by patients and providers. And here, if you look at the third pair of bars, the ones that are labeled 1 year ago, you'll see that we started to move in a kind of worrisome negative direction last year, where a larger share of respondents were concerned that the priorities were not doing a good job of adequately addressing treatment choices. This year's survey has moved back into the direction that we would prefer to see, where more people are saying, yes, they do address the treatment choices faced by providers and patients. And I think this is something that could in part be driven by some of the PCORI funding that we've seen as people have started to see, okay, what types of research are really being funded. They can start to see that it matches up better with what they might consider adequate research priorities. So hopefully that's a trend that we'll see continue with next year's survey. This is a new question that we added this year. New is also one of our key findings. We asked stakeholders how complete they thought the evidence base was for supporting the treatment decisions that patients and providers face. I'm not sure why we didn't add this question before. It seems like a very obvious question to ask. And stakeholders told us that there's really not enough evidence yet to support those decisions. 67% were on the negative side, the left side of this issue area, and only 13% said 5, 6, or 7, moving towards a fuller or complete evidence base. So we certainly have our work cut out for us in creating that informative evidence base. This next slide speaks to how transparent processes are for interpreting evidence. And stakeholders told us that there's really not yet a whole lot of transparency in the process that decision makers use to interpret evidence. There hasn't been a whole lot of change over the 4 years of the survey. Something we'd really like to see, more transparency in the processes that are used for this. This is also a new question, also one of our key findings. We asked stakeholders the extent to which real-world evidence is used in decision making. The left anchor is that it's not used at all. The right anchor is that it's widely used. And stakeholders told us that it's somewhat widely used. 30% thought it fell in that side, but 47% fell on the left side and thought that it was limited, not at all used. One of the big findings from our survey, I think, is that there's a great deal of opportunity to use real-world evidence, which is certainly going to be available in an increasing way. This next question speaks to the extent that treatment assessments move beyond the clinical focus and also include some of a more broad focus, such as quality of life or issues of productivity. This is an area where we haven't seen a whole lot of progress over the 4 years. Treatment assessments generally have been trending towards the narrow clinical focus, and there hasn't been a whole lot of movement towards quality of life, productivity. And this may vary depending on who you are, how you view this. I think a lot of patients might like to see things move beyond the clinical. Certainly clinical is very important and the major place where you would start. This is another new question that we added this year. There's a lot of concern that as comparative effectiveness research is adopted, that not all patients will have access to the treatment that works best for them, that it would be implemented in a way that speaks to what's best for the average patient as opposed to what's best for the individual patient. So the left anchor here is that the variability in patient response is not considered in treatment decisions. The right anchor is that it is widely considered. And here stakeholders said there is opportunity to do a better job of considering variability in patient response. The next issue area has to do with the extent to which purchasing of health care services is done in an integrated manner. The left anchor is a silo view of purchasing health services. The right anchor has to do with an integrated view of purchasing health services. And this is a case where we saw a little bit of progress last year. If you look at the pair of bars that's represented by 1 year ago, you see that we started to move in the direction of a more integrated view of purchasing health services. We thought perhaps this could be because of the growing trend for ACOs and other value-based types of environments. But this year we see that we've slipped back to the same level that we were at 2 years ago, and we're not quite sure why that might have occurred. So there's not a whole lot of integrated purchasing of healthcare services according to our stakeholders. Then the last slide that I have, the last issue that I'd like to talk about is outcomes-based contracting. The left anchor here is little to no outcomes-based contracting, and the right anchor is widespread outcomes-based contracting. We've seen certainly some movement over 4 years. 4 years ago, well, 3 years ago, the very first survey, 80% of our respondents were on the negative side of this, that there was little to no outcomes-based contracting. Now we're at 68. So there's certainly been a lot of movement on those left-hand responses. On the right hand, we started with 5% 4 years ago, and that's all the way up to 18. So there has been some movement towards outcomes-based contracting, but in general, there's still not that much of it. And again, this is something that we would expect to see more of as we continue to move into an ACO environment and a value-based purchasing environment. So that's what we found in our survey this year, and I'm eager to hear what Dr. Selby and Dr. Rich have to think of the results. So I will turn it back over to Dan.
Okay, thank you, Kimberly. And now we'll move into the more interactive portion of our program. Dr. Joe Selby of PCORI, and Joe, the floor is yours.
Okay, good morning, Dan. Good morning, Kimberly. I want to thank National Pharmaceutical Council for continuing to support this survey. It is always exciting to see its results come out, and I think, as the years go by, you get an increasing appreciation for how useful it is to have someone who's monitoring this over time. I said this last year, and I'll say it again, that I don't think we're going back in terms of getting to a position where we no longer think CER is important. I just have the feeling that once one gets an appreciation of the value of research that clearly compares two options across a range of outcomes, it is so obviously useful to a wide range of stakeholders that we're not going back. So I'm sure not surprised that people still think it's important. One of the interesting findings from my perspective is this sense that we're still years out from CER having an impact. That doesn't really differ much from the way it looked in previous years. And I'm going to put a question to Jean. My sense is that the CER literature, or just the medical literature, is increasingly filled with legitimate comparative effectiveness research studies. And I suspect that in good part that's due to the AHRQ investment that started in 2010 and whose results are now showing up. Pharma is likely contributing to this to some extent as well. And what this says is that, or the possibility it raises is that even though the studies are beginning to appear, they're not yet impacting decision-making. Decision-making can take a while. The results have to disseminate. The questions have to be readdressed, the evidence incorporated. But I think it's a very interesting question. If I'm right that there's more and more CER evidence appearing, then the next thing to ask is what's happening to the evidence? Is it being embraced any quicker than evidence in general tends to get embraced? And so I'd love to see, and perhaps PCORI can play a role in looking at that in this coming year. So I'll leave that to Gene just to get his opinion. Other aspects, I think, as Kimberly said, this is an astute audience of respondents, and they're pretty much following what's actually going on. PCORI is ramping up in terms of its funding. The methodology report is out. We're doing a lot of work in convening and priority setting, so to notice an increasing role for PCORI in those areas just fits with what's going on the ground. And I think to notice the ongoing importance of NIH and AHRQ in the methods and in the support of this research is also appropriate. I know this is a small sample size, so you can't make much of small shifts from year to year, but I was, Kimberly called it out, and I was a little disappointed to see that these respondents didn't feel that health plans and health systems were continuing to increase their engagement in comparative effectiveness research. I'm going to say that I think that may be a statistical blip just based on the sample size. PCORI has invested a lot in PCORNet, which is just getting off the ground, actually just got off the ground after this survey was complete, so perhaps we'll see a little difference next year. But PCORNet involves a large number of healthcare delivery systems across the country in using real-world data to address CER questions. And so I hope to see that trend return next year. And then the last thing I'll say is I really like the new questions. The question about the use of real-world data, the question about are we paying attention to variability in patient responses. We don't know about changes, but I think that certainly PCORI's efforts to require attention to variability in treatment responses among patients, and our emphasis on real-world data, especially in the new and large pragmatic clinical studies initiatives, have a chance of driving these proportions upwards in the years to come. So I'll stop and see what Jean has to say, and then look forward to further discussion.
Jean, go ahead.
All right. Well, thanks to NPC and for the invitation and for this ongoing work, and thanks to Joe for his insights and his question to me regarding the lessons from the evaluation of the Recovery Act investment in CER. And indeed, I am going to focus some of my comments on what we learned in evaluating the AHRQ CER investment. As I would guess everyone on the call remembers, in February of 2009, the Recovery Act was passed, which it appropriated an unprecedented $1.1 billion to expand public investment in comparative effectiveness research. Of course, this was sort of a unique moment in time where this research investment occurred in the context of an overall effort economic stimulus. Now, under the Recovery Act, in June of 2009, the Federal Coordinating Council and the IOM released reports that were intended to provide some insights and direction for the AHRQ investments. And by August of 2010, all of the RFAs and RFPs had been responded to, and all of the CER projects were awarded. And then this work continued from August 2010 until September 2013, when our evaluation ended. Of course, in the midst of this, in March of 2010, the ACA passed, contributing to an evolving environment for comparative effectiveness research, and of course, the establishment of the Patient-Centered Outcomes Research Institute and its ongoing investments. Now, since our evaluation ended in September of 2013, we could really only observe short-term or process metrics looking at what had happened under the Recovery Act to that time. But with $1.1 billion of investment, quite a few things did happen. There was a large investment in data infrastructure, resulting in many new or refined or more CER directed data sets for research. There was a substantial investment in human and scientific capital, including new and expanded CER training programs, and a variety of projects endeavoring to advance methods for CER studies. And of course, there were many research projects on comparative effectiveness research that were initiated. Lots of new interim reports, issue briefs, presentations, and other products. And some publications, we did take a look at what publications had occurred by September 2013, but probably not too surprisingly, as one considers the timeline for conducting a comparative effectiveness research project and then completing it and getting it through the peer review process. Publications were really just starting to emerge by September of 2013, and indeed, as Joe pointed out, lots of projects are starting to now, from ERA, are starting to now see the light of day. Now, in the course of our evaluation, we did take a look at what might be the long-term outcomes from these investments, both under ERA and under the ACA in comparative effectiveness research. And we recognized, working with our technical advisors, that really improved healthcare decision-making by providers and patients was likely to be, as Joe pointed out, really a long-term outcome rather than a short-term outcome. This process would require ongoing funding for CER projects to result in definitive findings. And of course, now PCORI is bringing that funding online. Further development of CER data infrastructure, and as Joe has mentioned, with PCORI and with investments by HHS, that data infrastructure is really getting expanded and starting to become available online to support CER work. We also identified that there were a variety of other factors that would mediate the ultimate impact of CER investments on healthcare decision-making, and some of those are touched on in the NPC survey. So, for example, what are the expectations of decision-makers to use CER? What's the motivation of delivery organizations to promote providers' use of CER? What are the public opinions? What are provider attitudes? How are payers promoting the use of CER? What tools are available to help clinicians and patients discuss patient preferences? We also learned quite a bit from our work in the Recovery Act on the challenge of conducting stakeholder surveys. Again, I want to agree with Joe on applauding NPC for taking on and continuing this effort. There are a lot of challenges to conducting stakeholder surveys. There's, of course, achieving representation from different stakeholder groups. And as Joe pointed out, the group of stakeholders that NPC is engaged are clearly quite astute, understanding, for example, the role of PCORI in developing methods, understanding the responsibilities of AHRQ for dissemination of CER findings. More typical sort of stakeholders who are going to be involved in using CER findings at the point of care would be unlikely to have such a nuanced understanding of the policy environment and the roles of these different agencies and institutions. But we certainly, in our own work, identified the challenge of getting representative responses from the other kinds of point-of-care stakeholders like consumers and patients, frontline clinicians, and busy delivery system leaders. We also observed in our work the challenge of different terminology and the fact that, for example, consumers and patients, certainly during the time of the Recovery Act, didn't have a very clear understanding of what comparative effectiveness research was, but we were very pleased to learn from them that once they understood what CER was, that they definitely would value this in having more of this kind of information as they and their providers came to decisions together at the point of care. Just another couple of observations. Regarding the survey question on availability of agreed-upon research standards, as I mentioned, in the Recovery Act, there were a number of investments in CER methods priorities that have been identified by the PCORI Methodology Committee. But really, at the end of the AHRQ CER investment, those methods, researchers indicated that there was still a lot more to be learned. Fortunately, PCORI, among others, is continuing to invest in continued methods work. But it's not surprising that, that the respondents recognized there was still a lot of work to be done on achieving agreed upon standards. Regarding the question on to what extent variability in individual patient response is considered in treatment decisions, well, of course, for clinicians and patients to really discuss these issues and apply that patient-centered research at the point of care, they will find that it will go much better if they have tools that help promote that conversation. And what we found through the Recovery Act investment is those tools were just starting to get developed. So there's a lot of work to be done to make that aspiration a reality. And then I do want to comment that on this issue of to what extent treatment assessments are incorporating a broad focus on quality of life. Certainly, again, in our focus groups, consumers emphasized, not too surprisingly, the importance of this evidence being applied to them and their personal situations. As I said, whether, how we develop the research and how we translate that research to the point of care is going to be important to achieving the full impact of CER down the road. So those are just a few insights that came from our own work on the Recovery Act investments in CER. And now I think we can turn it back over to Dan to take us through questions from the audience.
Right. Very good. Thank you, Gene. And yes, so I'm going to kick us off here with a question that I've had basically every year we've done this survey, and I think it's relevant to both Joe and Gene. But this is the 4th year in which the majority of the folks that we surveyed have said that they expect CER, they expect it will have an impact, but in the next few years, usually around 5 years. It's a horizon issue for them. And this is the way this question has laid out each of our first 4 years. So my question is, and I'll start with you, Joe, do you believe there will be an inflection point, a pivot point, where the respondents will start saying, yes, this is now a now issue versus a horizon issue? And and the question for you, Joe, is, when will that be? What's your best guess? And then Gene, same thing, with your experience in tracking the AHRQ funding, where AHRQ funding turning into reality, how long does it take? We know there's a long lead time on some of this research, but what's your best take on that question? Joe first, then Gene.
So yeah, that probably is the most compelling question to come out of this year's survey. One might think that would be beginning to change, but you've alluded to the fact that it takes more than doing the research or even publishing it to affect change. So I would say it's upon us, it's upon PCORI, it's upon AHRQ, it's upon health plans and specialty groups to take up this information, implement it into clinical practice guidelines, and implement it into clinical policy in ways that benefit patients. So I'm not going to be bold enough to say that there'll be an inflection point. I think it's going to be gradual. And I think that my sense is we ought to be studying this even as we're making increased efforts to drive dissemination and implementation. We should be studying just what's happened to some of this important CER as it has and as it is coming out to track it. I think everybody knows that comparative effectiveness research is highly valuable for making clinical decisions, but everybody knows equally that research doesn't change practice by itself. So it's on us all to take this research and do what's needed to get it disseminated and implemented. So we will all stay tuned. I wish 2014's survey results were here now, but it hasn't happened yet.
And Gene, any learnings from tracking the AHRQ funding in CER to help us understand, when we might turn the corner?
Sure. Well, I think one of the challenges that you face with your survey is while you have an excellent sample of astute respondents, they represent a diverse array of perspectives, and likely, there are different aspects of CER questions that are most salient to them. So I would guess that in your survey, it will take some time for all of them to be seeing near-term impacts from the AHRQ and the PCORI investments in comparative effectiveness research, just because, while there may be some really important CER studies that come out that affect one particular discipline, it may well be that some of your stakeholders are more sensitive to decisions and decision making, in a different arena, where it will take longer for CER to have an impact. So there are, and as I think Joe mentioned earlier, in many cases, just one really good CER study can't be expected to change clinical decisions. There have been a few examples of studies that really, just their mere publication affected clinical decision making within a year. For example, the studies on hormone replacement therapy and the relative effectiveness in postmenopausal women. But in many other circumstances, there have to be a number of studies. The professional community has to sort of incorporate these findings into the body of evidence. These need to translate into clinical practice guidelines, and then those have to be disseminated. So it's pretty clear that even if you've got a couple of great publications, it may take several years before those publications could have an impact at the point of care. So long story short, I think I feel confident that we'll continue to see progress in this area, but I suspect it will be years before all of your stakeholders say, absolutely, CER is having an impact right now.
Got it. Okay, now we'll go to some of the questions that we've gotten off of the webinar. I'm going to direct the first couple to Kimberly because they're somewhat clarifying questions around the survey itself. First question is, when you're talking about decision-making, do you mean bedside decision-making or treatment path selection, what health services to offer, or simply economic decision-making, profit optimization? That's the question. Kimberly?
So this question actually came in from two different folks, and I think it refers to when I was talking about the treatment decision-making and talking about the clinical versus the non-clinical, which moved into quality of life and productivity. And I misspoke. I believe that I talked about treatment decision-making as opposed to treatment assessments, which confused a couple of folks. So when we were talking about the difference between the clinical treatment assessment versus moving into the non-clinical areas such as quality of life and productivity related to treatment assessments, that's really about the assessment of value that's happening in the comparative effectiveness research, not the decision-making that's happening with the patient and the provider. So apologies for the confusion there, and thank you for the opportunity to clarify that question.
And are there differences, Kimberly, between the different stakeholders surveyed, and did it show differentiation?
We get this question every year. It's a great question, and I completely understand why folks would like to know how the different stakeholder groups respond to these various questions. Unfortunately, our sample size is small enough that if we were to try to break the individual groups into pieces and look for trends, we'd really be dealing with a small sample size issue there. So although we sometimes look at them internally just to kind of get some ideas of trends, the sample sizes are too small to talk about them publicly.
The next one is for you, Joe. What is PCORI's evidentiary standards and research agenda in regards to biosimilars? Do you have any projects or funding in the works for studies around biosimilars, or is it too soon?
It may be too soon, Dan. I'm definitely not aware of a study that we funded a comparative study we funded related to biosimilars. But as I always say when somebody asks me a question like this, we'd be very open to it. It sounds like an important area for CER. So if somebody has a project that's ready to go, we'd be very interested in hearing about it.
Okay. There's a question that's come in asking, is there a good source or consensus on what methodologies are the most credible and useful to payers, short of the head-to-head comparison? Which other comparisons are reputable? And can you provide a web link? Does one exist? I'll take this opportunity in this question to speak to an ongoing project that we have here at the National Pharmaceutical Council. As many of you know, payers are increasingly looking to new types of evidence. We see that in what is requested in dossiers. We've also seen that many payers are welcoming methods and tools such as the CER Collaborative. Now, the CER Collaborative is an initiative that we have underway here at NPC, along with the Academy of Managed Care Pharmacy and ISPOR, the International Society for Pharmacoeconomic Research. And we've developed web-based tools that do exactly what the questioner is asking here, comparing individual studies, assessing individual studies, and then comparing multiple studies as well. So if you want more information on that, it's available on the website for the collaborative, which is cercollaborative.org. We also did a webinar on this back in March on this very topic, and you should be able to find the archived webinar on our website, npcnow.org. And there were also 3 very recent articles published in Value in Health, the journal, that were just published recently, and you can look at those as well. So that's a good source there, I think, for if you're interested in comparisons and other methodologies, as the question states. So I'm going to ask this one of Joe in the few minutes that we have left. This was also the first year, Joe, that we asked some of these new questions that you also mentioned in your presentation about whether individual treatment effects were being taken into account in the research and healthcare decisions. We know that PCORI has been active in supporting research that considers patient differences. With PCORI's efforts in this area, Joe, do you think we'll see any changes in this answer next year or down the road, perhaps?
Well, I am optimistic that increasingly research is going to go beyond simplistic comparisons of the averages in 2 groups and pay attention to possible differences among patients in how they respond to therapies and frankly, which therapy is better. But it's not going to be easy because, as we all know, looking at these interactions or this heterogeneity in treatment effects takes much larger samples. Getting much larger samples, especially in randomized trials, today costs a lot and is really the limiting feature of clinical trials. So we have a ways to go. PCORNet is one effort to make it feasible to conduct larger pragmatic studies and to look for treatment heterogeneity or differences in response in much larger trials. PCORI also offers great opportunities to use observational methods, big data methods, to get at least signals or hints that different patients may respond differently to particular treatments and the characteristics of those patients. So we require every applicant to tell us how they're going to attend to this, and we recognize that limits in budgets make it infeasible for every study to examine every possible difference in treatment responses. But I think PCORI and others are putting the pressure on to be more attentive to this, and I think that the large observational studies are going to point to more opportunities, more hypotheses, point out more hypotheses to be tested, and this will drive better targeting of therapies in the longer run and better outcomes. Genetics is one area where we have just a lifetime's worth of patient traits to explore for how they affect and interact with treatments, but it's certainly not the only one. Educational level and language and comorbidities are other areas where age even, where treatments may work well for some and may have net adverse consequences for others. So a lot of work to be done, and I think we owe a debt to comparative effectiveness research per se, and to the framers of the PCORI legislation for making it a requirement that we look more than we have in the past at these possibilities.
Next question I'm going to direct to Kimberly here at NPC. Is there a valuable published case study demonstrating how an effective CER study can impact treatment decisions? And if either you, Joe, or Jean have a comment on this too, we'll jump in, but Kimberly has
Sure.
Speak to this.
We actually, NPC published an article co-authored by Bobby Du Bois, Michael Lauer, and Eleanor Perfetto. It was published in the July 2013 Journal of Comparative Effectiveness Research, and it's called When is Evidence Sufficient for Decision Making? A Framework for Understanding the Pace of Evidence Adoption, and it actually goes through case studies in 3 areas: statins, drug-eluting stents, and bone marrow transplantation for breast cancer, and works through when the evidence is sufficient to impact decision-making, and would actually make very interesting reading to answer that question.
And Joe or Jean, if you have any other recommended reading for the audience on the topic?
Well, there is a very nice paper that I saw about 8 months ago. The first author is Mark Hlatky, H-L-A-T-K-Y, and it was in the Annals of Internal Medicine. And it really, it was about the comparative effectiveness of stenting versus coronary artery bypass grafting in the Medicare population, and actually showed a lot of treatment heterogeneity as a function of a number of patient characteristics. Sometimes cabbage was the clear winner, and sometimes stenting looked to be at least as good, if not better. And the way that that the authors laid out the predicted benefits was, to my eye, fairly novel and a nice model that could be emulated in other studies. So it was in the Annals of Internal Medicine, and it was late 2013.
Great. And just one more quick one, Joe, for you. What other surveys might PCORI be conducting to assess CER in the landscape? Do you have any of your own survey work that you're conducting?
Well, Dan, I'm not completely prepared to answer that. I know that we do have some survey work in development, but I'm afraid I can't give you the details just because I don't have them at hand. I can tell you, though, that it's part of our own evaluation plan going forward to monitor in a large number of stakeholder groups the awareness of and use of CER evidence. But I can't give you a much more detailed answer than that right now.
Got it. Okay. Well, we are already prepared to do this survey again for next year, and so folks can tune in again in about 12 months, and we'll have the next round of surveys on the topic. But I think we have come to the end of our time, and I want to thank both our speakers, Joe Selby and Jean Rich, as well as our speaker here in the office with me, Kimberly Westrich from NPC. So all of the materials that we discussed and the questions as well will be on our website, and the archived version of this webinar will be up as well at our website, npcnow.org/CER Survey 14. So thanks everyone for joining. Thank you again to our guests. Have a pleasant day.